have like new features, we'd like to introduce them to you just so that it gets a little easier for you ahead in the session. I'm sure you all can see on the right-hand side lower corner a tab called activities. And once you click that, you will be able to see options like Q&A, where if you have any questions during the session, feel free to put your questions there and we will respond to them as soon as possible, or probably by the end of the session. At the same time, now we also have another feature called the poll, where sometimes where I'll be asking questions, we will be putting out a poll and you can just click on that and just respond to the answer that you think is the most probable. So these are mostly the things about the new things that we've done getting your feedback in. Now coming to our session. So this, as I mentioned earlier, this is about the types of cohort studies particularly, and something about case control studies, what is odds ratio, how to calculate that, and how to interpret that. Okay, so the major objective of this session would be talking about exposure versus disease, similarly talking about independent versus dependent variables, then talking about the types of cohort studies that are available. More about cohort studies will be dealt in another session, and finally talking about case control studies in particular detail. So talking about exposure versus disease. So what is exposure? It is anything, any factor that may contribute or prevent the formation of a disease. And this is nothing but invariably an independent variable, because this does not depend on anything. And as we go ahead and as we look through the examples, I think this should be more clearer. And what is a disease? A disease is the outcome that is being investigated. And this is a dependent variable because a disease is always dependent on the exposure, but the exposure or the risk factor is not dependent on any other variable. So now we have an example. The first one is smoking during pregnancy and preterm birth. Okay, I would like everyone, any one of you, to volunteer or just put it on the chat box. What do you think would be the independent variable here? Independent variable, again, I'll repeat what that is. It is nothing but the exposure, the risk factors. They are independent variables. Great. I see a lot of answers. Smoking, correct. So this is the independent variable. And now, obviously, though now we know the independent variable, we know the dependent variable. That is the preterm birth. Wonderful. Let's do another question. So this is the answer. Let's do another question. There is a relationship seen between OCP exposure and DVT development. So what in this case is the dependent variable or the disease? Wonderful. I see a lot of answers. DVT, correct. So as you all have rightly said, that the exposure here or the independent variable would be OCPs, but the effect or the dependent variable is DVT. Now, a final example. I think this is pretty simple. So what is the dependent variable here? In HPV and cancer formation. So HPV leads to cancer formation in most cases. What would be the dependent variable in this case? The cancer, yes. Cervical cancer would be. Wonderful. You guys have got this concept right, correct. So it's wonderful to see that. So the independent variable, as I mentioned, would be HPV, while the dependent would be cervical cancer. Now we come to the second objective of this session, that is discussing the different types of cohort. So primarily, there are three types of cohorts. One is a prospective cohort. The second would be a retrospective cohort. And third is a combination of the both. And that is called the ambidirectional cohort study. Talking about prospective cohort studies. So in general, I think one rule of thumb would be that prospective cohorts are always forward-looking. So in every case, it always goes from exposure to disease. In this, what is the difference between prospective and retrospective? Now that's the next question. So prospective is like we're going to look at events in the future. So we start, so as you all can see an arrow that shows that the study begins here. Then we follow that patient in some time for a period of time. And that's why it is not only forward looking, but the actual disease happens in the future. And usually the exposure or the risk factors is always present at the beginning of the study. And then we follow them while they develop the disease. And a very good example to understand this would be like to find an association between smoking and placenta previa. So what we did here is we took two groups, smokers and non-smokers. And with that exposure, with these two groups that are being exposed versus non-exposed, they are followed over a period of time. And then they're checked if they develop placenta previa or not. As we can see that this, for example, right now we're doing the study somewhere. So this study is supposed to happen in 2025, and currently we're making a study design. So it would start somewhere in 2025, January, where we would take two groups, smokers versus non-smokers, and then we would follow them throughout pregnancy and then see if they develop placenta previa. And one of the major disadvantages of prospective cohort studies is that it needs a lot of follow-up. It requires a lot of time and money. So these are certain drawbacks of this. And at the same time, it leads to some biases and errors. So one of the biggest biases would be Hawthorne error. So what is that? That is, usually subjects change their behavior during the study when they are being carefully watched. In this case, what patients might ideally do is those who are smoking might reduce their frequency of smoking so that their outcome is not it's not diseased. So here, this is what Hawthorne error is. At the same time, there is loss to follow up that is called attrition, and that is very easy in cases of cohort studies, and especially prospective cohort. Now, even though cohort is considered much better than case control, but between retrospective and prospective, retrospective is similar to a prospective in terms of it's always looking from exposure to disease. But in this particular case, what happens is that the medical records or hospital records are looked into the past in order to look at the exposure, and the disease is in the present time where the study is happening. But at the same time, even though the disease has already occurred in the present, we start with the exposure groups. And that is more clear with this particular diagram. As you all can see that the study begins where the arrow begins and the outcomes have almost already come. But the thing is, we go back in time and do not start from outcomes. We start from two groups, that is exposed versus non-exposed. And then we check what their outcomes were. And this is primarily better because we do not have to follow up these patients. We already have the data available in the form of existing records, past employment, medical records, etc. And in this particular thing, as I mentioned, the outcome has already occurred before the start of the investigation. Now, a good example over here would be to explain this, that the first step would be selecting a study group, that is exposure group, that is smoking, versus non-exposure group. In this particular example is non-smokers. And then analyze in the present how many actually develop placenta previa. So a good example with respect to timeline would be that we're right now in September 2024. We go back in records in November 2023 and look at pregnant women who were smoking versus those who are not smoking and create two groups of 100 participants each. And then check our records in 2024, seeing that how many actually develop placenta previa over the period of pregnancy. And then we can analyze the results accordingly. So now between retrospective versus prospective, just like pros and cons. So with respect to information, retrospective can have incomplete or not incomplete, but less complete or less accurate as compared to prospective, because in prospective we are looking forward and we can actually see we can look at the different outcomes, etc. But with retrospective, it is mostly depending on the exposure details that are already available, and there is not much that we can do or modify or check over. When also we cannot see the new exposures with respect to retrospective approaches as compared to in prospective, that can be seen because it's happening in time. But retrospective is having less costly, and it can be done in a shorter period of time, whereas prospective would be more costly and taking a longer period of time because patients need to be followed up for that entire period. And now a quick question. We know that both retrospective and prospective are having their own pros and cons. What do you guys think is much better, a prospective approach or a retrospective approach of a cohort study? You can put it in the chat box. You can unmute yourself and say that. What do you think? A prospective, okay. Okay, we have a lot of answers saying a prospective study. Okay. So it's ironic here, but a retrospective study is kind of considered better. The reason being that, as I mentioned, some drawbacks with prospective. Firstly, there is Hawthorne error, as I mentioned, that participants tend to change their behavior, and therefore that affects outcomes and disease formation. So that is one of the biggest things. Secondly, loss of attrition. It is very easy to lose. Following up patients can be a little hard, and it's easy to get off track on like the patients that we have. With retrospective, it's just easier to look at medical records. Secondly, as we mentioned, that it is less costly and it takes a shorter period of time. Therefore, retrospective is slightly better than a prospective cohort study. But that being said, a cohort is always better than a case control study. Now, what is an ambidirectional cohort? As we mentioned, that both prospective and retrospective study designs have certain pros versus cons. But so a best case scenario would be a situation where we can get the best of both worlds. So this is a combination of retrospective and prospective study. So again, the study design in this particular situation would be selecting two groups. One would have smoking as the exposure. The second would be non-smokers, and both of these would be followed up, and the analysis would take place at the end. So here but here the timeline would seem a little different. So we start with two groups, that is smokers and non-smokers. In this particular example, hypothetically, in the month of March 2024, we're here in present September 2024, where we've already had these two groups and we've looked at exposures at the beginning of pregnancy in the past. And now we can analyze for the disease in the groups in December 2024 in the future. So we can now follow up these patients to see if they have placenta previa or not. And this is much better because the follow-up period of these patients is pretty less as compared to the initial prospective study design. At the same time, it also gives us the pros of a retrospective where a lot of data and information is already available. So as you all must have guessed, among cohorts, a prospective is considered good. Retrospective cohort is considered better, and the best case scenario is the mix of both. So we get the best of both worlds. And this is just a quick review of what we discussed in our first session, where we spoke about how case series, case reports, editorials, and animal research are all at the base of the pyramid. A little better than them are case control studies. Superior to them are cohort studies, and finally on the top of the pyramid, first we have the RCTs and the blind, double-blind studies, and finally the systematic reviews and meta-analyses. So just a quick review of what these three are. I would appreciate it if one of the participants can just look at this figure and explain what were the three differences between a prospective cohort, a retrospective cohort, and what was a mixed cohort, in your own words, or probably with using the same example that I explained. And I would help in between, so feel free to just volunteer. Okay, I'll go first. I'll try to explain the prospective cohort study. So what happens with the prospective cohort study is that at the start of the study, we create two groups, exposure versus non-exposure, and then we follow them in the future over a period of time and see the outcomes, disease versus non-disease. So as an example would be starting with two groups, that is smoking versus non-smoking, following them up for 9 months or around 9 to 10 months of pregnancy, and then seeing their outcomes. What is a retrospective study? Would anyone like to just summarize what that is with the help of the same example as I used? Shri, would you like to just explain that?
Sure. Could you please repeat your question?
Yeah, the question is just like we're just talking about, this is just a summary slide, the summary of like what is retrospective cohort study is.
Uh, sure. So you want me to give you an example?
Yeah, sure. Like the example that I used, you can probably just summarize with the same: smoking and placenta previa development.
So a retrospective is when we're like going back in time is basically retrospective, and prospective is forward. So for example, we had to go back to a data which was done previously, so perhaps in 2013, and see if the exposure led to the development of placenta previa. So this is done back in time, so it's called retrospective.
Wonderful. Thank you so much for summarizing this for us. So retrospective is, as you mentioned, is back in time. And this is a very, very important thing that you mentioned, that we're looking here when we talk about prospective and retrospective cohort study, types of cohort study designs. We're talking in terms of time, because in general, a cohort is a forward-looking study. So it's a prospective study because we always go from exposure to outcome. But with respect to time, it is there is a retrospective type that occurs where we can go back in time and just look at records and see the exposure. And the best, as I said, the best case scenario would be a mix of the two, where there is some prospective element where we are looking at the disease formation, at the same time some prospective component where we're just looking at the medical records, so that it just gets easier to finish this in lesser time, and it can be done with lesser resources. Thank you so much, Shri. Okay, now we've come to our final objective for this session, and that is case control studies. So what are case control studies? Case control studies are kind of like opposite to cohort studies. So what primarily occurs in them is that instead of looking forward, that is from exposure to disease, here there are two groups where there are two groups of disease, the one with disease, one without disease, and we look back in time to see if there was an exposure or not. So, and therefore sometimes this is called the Trohawk study, like the opposite of cohort, because here we start with the risk factors. Instead of starting from the risk factors to disease, here we start with the disease. And this would be a retrospective type. As I mentioned, cohorts are prospective types of studies. These are retrospective types of studies because we're going from exposure to disease. This is a chart that we discussed in our first session, and just like I'll quickly remind you guys that it was we're talking about under non-experimental and observational studies. We have two types, that is population-based and individual-based. Among population-based, we have examples like different types like health surveys and ecological studies, while on individual level we have analytical studies, and today we're primarily talking about case control right now, and before we just spoke about types of cohort studies. Again, this slide very well depicts the point that I was making, that it's a retrospective type of study, that is looking back in time from disease to exposure. Now this is an example that we're using to just compare case control versus cohort right here. So in a case control study, what happens is, so we take two groups, that is cervical cancer patients and those who don't have cervical cancer, and back in time we go and see if they had smoking exposure or not, and then analyze. So this is a case control study. But in a cohort, what happens is that we start with two things, that is the exposure, that is smokers versus non-smokers, and then we follow them up, or just follow them up after a period of time, see whether they have developed cervical cancer or not. Okay. Now it would be a good time to just like see, Rajvi, please can you just upload the polls to our meet? So as I mentioned earlier, you guys can use the activities. You can
All
see
the
the
polls?
activities.
Sorry.
Yes.
All of you want me to put all the polls?
The ones where we just have to choose whether it's a case control study or a cohort study.
Okay.
Yeah.
Just a second.
So and you guys can just use the tab below on the right hand side where there is an activities button, and you all can see that. I think the first question is it usually what is usually retrospective in nature? This is something that I emphasize throughout. Whether is it a case control that is retrospective or a cohort that is retrospective? I would appreciate if you all can like choose an answer. And if you all are finding any difficulties in finding this poll, please feel free to unmute yourself and let us know. The second question is, it is what is usually used for rare disease presentations, a case control or a cohort? This is going to be more like a guess, which I will be explaining further on. This is just a guess. You all can guess either what you all think can be used. Another study would be like a large study population. Usually, what kind of study design do we prefer for large sample sizes, like a cohort or a case control? And then finally, which one of these two can help study more than one diseases? So this would be just like applying all the information that I spoke about, like seeing which goes forward in time, behind in time, and that's how you all can like kind of guess what should be the answers. It's so nice to see that a lot of you have voted. So a lot of people have voted that usually a retrospective is a case control, which is wonderful. A case control, as I mentioned, is retrospective because we're starting with diseases and we're looking at exposure in the past. So wonderful. For the next one, we've got like kind of a lot of responses for case control, which is again correct. For rare diseases, we prefer case controls over cohort because as I will be mentioning ahead, is that in cohort we usually take large populations, and with case controls we can also do it when we have very small sample size, and therefore that's why it becomes very good to use case control study design for rare diseases. Similarly, we see a lot of like responses for cohort for a large sample size, which is correct. Usually, a study population is usually large in cohorts. And finally, here I think everyone's got it right on point. A study that can a study design that can help study more than one disease would be cohort study. Okay, so moving on, this is just like a quick summary of everything that we've discussed. And it seems that you guys were getting concepts, so that's like wonderful. So as we already discussed, case control study is usually retrospective. It is cheap. It always shows quick results because, again, we start with diseases and we're just looking at exposure in the past. It's appropriate for rare diseases, but one of the biggest problems that it can only study one disease, which is good with cohort because you can study multiple diseases because we're starting with the exposure and not the disease per se. And it is appropriate, also more appropriate. Cohort is more appropriate for common diseases. It is always prospective, although we spoke about the types which are in relation with time, but prospective in its study design, like starting from exposure to outcome, and then usually it's more costly and takes more time. So those are a little few of the disadvantages associated with cohort studies. We've already discussed the limitations here. Now, the definition of what observational ecological, what are the different types of ecological epidemiological studies. So there are like case comparison study, a Cohort study, or a case history study. I mean, these are some names for case control studies. And as I mentioned, what the study design should look like, we start with two groups, primarily disease versus non-disease, and then we look at the risk factors that are present or absent in the study population. Now, talking about the features of case control study, it is supposed to be retrospective, and both the outcome and exposure are known at the start of the study. Therefore, it is less time consuming and requires lesser amount of money. And a control group is always taken. Now we will be talking about primarily the steps of a case control study. So first, talking about the research question. In this case, we're discussing, just a minute. In this case, we're discussing, is smoking in pregnancy a risk factor for placenta previa? So as we discussed in the previous session, what would be the null and the alternate hypotheses? The null hypothesis is always almost opposite to what we're testing, or what we're expecting the outcomes to be. So that is, smoking is not a risk factor for placenta previa. While the alternate hypothesis is smoking is a risk factor for placenta previa. Usually our aim with studies is that we reject the null hypotheses and accept the alternate hypotheses. Now, coming back to the main steps, this was just a quick preview of what we discussed in the previous sessions. So, so first we start with selection of a case and a control group. And what we would ideally try to do is matching, which I'll be talking in the consequent slides so that it'll become a little easier for understanding. Then we try to find the exposure and measure exposure, and then finally the analysis and interpretation part. So in this case, the selection of the study group would be based on diagnostic criteria and eligibility criteria. In the example that we're currently talking, that is smoking leading to placenta previa development. So for placenta previa, we will be using our ACOG criteria as the defining criteria for the cases of placenta previa. And usually these, when we talk about eligibility criteria, we usually try to include new cases as compared to old cases, because what happens sometimes with old cases that there might be changes in their exposure due to, because of some medical advice that is given once the disease has been diagnosed, and because of awareness also of the disease in the patient, and therefore that could change the outcomes. So therefore we try to take incident cases as compared to prevalent cases when it comes to selecting the disease population. In this case, we selected 100 diagnosed cases of placenta previa who met the diagnostic as well as eligibility criteria. And usually our source is hospital-based or population-based. Now, how these two groups have to be chosen. So usually I'm talking about the control group that has to be chosen particularly. So usually the control group is the one that does not have the disease, but that is not enough for the selection criteria of controls. So controls should represent the distribution of exposure in source population of cases and should emerge from the same study base. So sometimes, for example, if someone does not have placenta previa or does not have any other complications during pregnancy, we still need to make sure that some of them still are from the same source and still some of them are smoking. Although we do not look at how many are smoking at this point, but we should see that whether they represent like the source population. And now regarding selecting the controls, selecting from the same source population gives rise so as I mentioned, one of the criteria is to select from the same source where the cases have come from. At the same time, selecting independently of their exposure status ratio, selecting them independently of the exposure, as I mentioned, not to see that how many exactly were smoking versus non-smoking while choosing that population. The ideal selection ratio that we like of cases versus controls would be 1:4, but a minimum of 1:1 is advised at all times. Now we have two sources of controls. Again, we have hospital-based and population-based. And here we talk about the strengths of both. So a population is a much better and a defined source to pick up patients as well as controls from. And it is easier to make certain that cases and controls come from the same source. At the same time, exposure histories of controls are more likely to reflect and be similar to the cases. Whereas when it comes to hospital-based, these subjects are more accessible and they're more cooperative and they're more likely to participate in the study. And at the same time, as I mentioned, it's very easy to collect exposure information from medical records and biological specimens. Now, when we're talking about matching, it's very important to match these two groups of cases and controls so that we can say that the particular exposure only led to the outcome and there were no other variables that actually influence the outcome of the disease, which becomes really, really important. We do not want confounding variables, and this is a term that will be further explained and elaborated in the further sessions, but we don't want other factors affecting the outcome, and therefore matching becomes really important here. So there are two types of matching that occur. One is group matching, while the other is individual matching. So in group matching, what we primarily do is create subcategories like age, occupation, etc. And we match the whole population based on that. We match like the whole population of cases and controls among these particular categories. While individual matching, what that is primarily is that we select controls individually and match each case. Now I would like to hear your thoughts on the chat box. What do you guys think is more doable or beneficial, a group matching or an individual matching? And you all can respond to either. That's completely fine. What do you all think? What is better, group matching or individual matching? Group. Wonderful. This is the right answer, group matching. And that is primarily because just a minute. That is primarily because it is easier to match age and match populations as compared to individual matching. And sometimes what happens with individual matching is that we match each and every characteristic and criteria, and sometimes that may not even influence the disease outcome. For example, in this case, we might match individuals with similar immunities or those with stronger immunities, but those don't really have any impact on placenta previa. So individual matching or like overmatching in this case does not really affect the outcome. And it is a little more less feasible as compared to group matching. Again, we start with an example here to understand that how we can do group matching with respect to the example that we have been discussing for some while of placenta previa and smoking. In this case, what we can do is we'll select the group with less than 35 years in both groups, that is cases versus controls. The reason being that we don't want young participants in the control, as they will not be very likely to develop the disease. So in case if something like this happens where we have a lot of young participants in the control group while older patients in the cases group, age is supposed to affect placenta previa. So older patients are likely to develop placenta previa, and we don't want age to be a factor in hindering or just altering our results. Similarly, uh, the gravidity of the patient. So the number of times that they have passed 28 weeks of pregnancy, and the more the number of pregnancies, the more chances of placenta previa. So in case if there is a way that if we do not do group matching, we might have a lot of multi-gravid patients in the study group, and this might again affect the outcomes. So in this particular group, how we would do group matching, ideally, we would take patients less than 35 years of age in both cases and controls, as well as primary gravid patients. And as I mentioned earlier, that if we individually match patients, it is very difficult practically. At the same time, we could be, ending up with overmatching where a lot of factors that we are matching don't even really affect the disease. Step 3. So step 3 of this would be, again, obtaining data for both cases and controls, and seeing whether they are smoking or not. And this is a very, very good diagram that really helps understand what that is. So again, we started with cases and controls, 100 patients each, and then we go back in time. So this is in 2024, we have these cases and controls. We go back in time in January 2024, we look at whether these patients were smokers versus non-smokers, and we found that number. Now, in order to analyze this information, we will use something called the odds ratio. It is nothing but the odds of developing a particular disease. And odds ratio is the statistical analytic tool that is used mostly in case control studies. While for cohort that we discussed, we usually use a relative risk. And this will be dealt with in detail regarding cohort and the interpretation and the statistical analysis in the next session. Right now, we will just be focusing on odds ratio. And this would help us quantify the actual relationship between exposure and controls. So as I mentioned, odds is the ratio of the number of times that this particular event can occur, divided by the probability of non-occurrence. And it is usually, we can understand this better with an example. This is a non-medical example just to understand what odds ratio is. So Sean makes 65% of free throws. So what are the odds in favor of making a free throw in case of Sean? So as I mentioned, it is the probability of a event occurring divided by a non-occurrence of that event. I don't want the actual mathematical answer, but you all can just tell me like 0 point something divided by 0 point something. So what is that? You all can unmute yourself or put it on the chat box. Yes, I see Raj Lakshmi has given her answer. Would anyone else like to try? Just a quick thing to let you all know that when we deal with the odds ratio, we do not like to use percentages. Instead, we like to use fractions. So in this case, we would be using something like 0 point something divided by 0 point something. Yes, I see answers. Wonderful. So as you all have mentioned, it is 0.65 divided by 0.35. That is 1 minus the amount of free throws that are possible. And that's the odds. Or the relative odds. Now coming to how we can actually apply this in our own scenario. So we have like a tabular form made where we have disease versus no disease versus exposed and unexposed groups. And hypothetically, we've given the values as A, B, C, and D. So here, what's the odds ratio exactly? It's the odds that a case was exposed divided by the odds that a case was control was exposed. Okay. And when we talk about the odds that a case was exposed, we see about individuals that were exposed divided by individuals that were not exposed among cases, and similarly in controls. And as you all can see in this particular diagram, so for the exposed odds, in case of disease, we will have A divided by C divided by the odds that the control was exposed, that is B divided by C. And when that entire thing is like rearranged, that would be AD upon BC. So the next slide talks about the derivation that I was trying to explain, but the final formula that comes out of all of this is AD divided by BC. So as I mentioned, so first we look at the odds of a case divided by the odds of a control. When we talk about the odds of a case, as if you all recall the tabular column, the first column was the disease. So A divided by C upon D divided by D. And then we get this AD upon BC formula. Now we talk about interpretation of odds ratio. So how can we interpret odds ratio? So if odds ratio is 1, so that means that the odds of exposure among both cases and control was the same, and therefore the exposure is actually not related with the disease. When we talk about an odds ratio more than 1, that is, the odds of an exposure among cases are higher than controls. Therefore, what we see is that the exposure is positively associated with the disease. Finally, another example would be odds ratio less than 1. And that is clearly understood that the exposure is negatively associated with the disease. So the odds of exposure among cases are lower than those of controls. So this is how the interpretation of odds ratio happens. So 1 just means that there is no relation. More than 1 is positive. Less than 1 is negative. Okay, so now we have an example, the same one that we've been following out throughout this entire presentation. We have placenta previa patients and controls, and then we have smokers versus non-smokers. We found out values for this and put it in a tabular form. Would anyone like to tell us what the answer would be? Again, I would be like A into B divided by C into D in terms of like values. Can you put that in the chat box? What do you think should be the answer for this? How would we calculate odds ratio in this case, keeping in mind that this is a case control study design that we're discussing? I'd like to give a little hint here. You all can use the AD upon BC formula and try to like apply it to this. Okay, we have the exact answer here. Okay. Anyone else would like to try? I mean, thank you very much, Hafsa, for giving us the answer, but I would also appreciate if you all just can give the step that what should be multiplied by what and divided by what. Wonderful. We see a lot of answers. And yes, most of you all are right. It is 70 into 60 upon 30 into 40. And it also, I've also seen someone saying that, and someone said 70 upon 30. That also is correct. 70 upon 30 divided by 40 upon 60. So that all comes out once the entire thing is solved. It's 3.5. So now let's talk about how these results could be interpreted. So what does 3.5 signify here? Feel free to put that in the chat box, or even like unmute yourself and like let us know. As I had discussed how odds ratios can be interpreted. Would anyone like to try and put it on the chat box? How do you all think should be this odds ratio of 3.5 should be interpreted? Yes, positively associated with the disease. Thank you, Hafsa. That is correct. Placenta previa, here what odds ratio does, I think, is not only give us a qualitative measure that is showing a positive, negative, or no association, but it also quantifies the association. So in this case, we have it quantified, that is placenta previa has a 3.5 times higher odds of presenting with a history of smoking as compared to healthy individuals. And this can obviously imply that smoking is strongly associated with placenta previa, but also tell us the degree to which it is strongly associated. And odds ratio tells us if the exposure to the risk factor was higher among cases in comparison to controls. So that is like a wonderful thing. And this interpretation of odds ratio is considered a little weaker than relative risk of cohort studies, because we've already seen that cohort studies are fare much better because they're followed up, and they use a lot of more participants, a larger population size, sample size as compared to a case control, and therefore an odds ratio is considered relatively weaker as compared to a cohort study. As compared, yes, to a cohort study. And now we come to the advantages of case control studies. So as we've already discussed, so this is just like a repetition of all the things that we discussed during our session, that it is really good for examining rare outcomes or outcomes with long latency. And the good part is that it can be done really quickly. It's quite inexpensive, and it requires fewer subjects, doesn't require a very big sample size. At the same time, multiple exposures or risk factors can be examined. The way we were talking about cohort studies, where we can study multiple diseases, your multiple case risk factors or exposures can be studied. And now I would like you guys to just put on the chat box what do you all think would be the disadvantages of case control. Okay, I can help you all with one. One of them would be that patients who are diseased, so since we're starting with the disease versus non-disease groups, there can be some bias where if diseased patients are asked regarding their exposure, they remember their exposure much better, and they're more likely to report that exposure as compared to those who have not developed the disease. For example, if placenta previa patients are asked whether they started smoking during early in pregnancy and were they smoking, they would remember their exposure much better as compared to the previous patients. Yes, one of the bigger disadvantages is that it is dependent, as Sana has rightly said, that it is dependent on past records and it's history dependent. And yes, another thing that you all have mentioned, Raj Lakshmi, thank you for like putting this up, that yes, it is retrospective in nature. So we're looking behind, and sometimes it's just harder to get these records. Sometimes they're just incomplete, and it's very history dependent. As you all have rightly said, that it is, as I've already mentioned, and you all have also mentioned, that it is like based on a recall bias. And here we're only looking at single outcomes. We cannot look at multiple diseases the way we were doing it with cohort studies. So that is another bigger disadvantage. Another thing that could be a disadvantage is that incidence is not calculated in this case. Since we're starting with two groups, that is disease versus non-disease, we're not seeing the disease actually form. And therefore, that is why incidence is nothing but the new diseases that are formed or that are added to the population. And in this case, we cannot find the incidence. So these are some of the disadvantages of case control studies. We have come towards the end of the session, and we've discussed all the three major objectives of our session. Would anyone just like to unmute themselves and just tell us what are like the three major objectives that we discussed, and what can we just be like a few takeaways from this session, or just what we discussed? Rajvi, would you like to just tell everyone, all of us, what do you think are the major takeaways, or just like major summaries of what we discussed during this session?
Yeah, so we talked about dependent and independent variables, and then all the different types of cohort studies, prospective, retrospective, mixed cohort studies, right? Then we talked like which is a better type of study. We talked about case control studies and the difference between case control and cohort studies, the limitations of these types of studies. Then we also talked about the steps of a case control study in a bit of a detail. Then we talked about different types of matching, how it is done, what are the advantages, disadvantages. We talked about odds ratio and how to calculate it. And we talked about the advantages and disadvantages of case control study as well.
Wonderful. You've given like the perfect summary to what we've discussed and what are the major takeaways. We will also be sharing this PPT for your reference at the end of the session so that you all can just go back and see it. At the same time, very soon, we will be putting our post-event questionnaire on the chat box. This link would be active for 2 hours up till about 10 p.m., where you all can fill it up. And as I've already mentioned, the criteria at the beginning of the session that one must get at least 70% correct and above in order to be eligible for the certificate. So it was wonderful having you guys. At the same time, if you all have any questions, feel free to put it in the Q&A section. Or just on the chat box, and we're happy to answer questions either on the chat box or in the Q&A section that you can see. Okay, case control study, since both are retrospective. Okay, that's a good question, Hafsa. So here, when we talk about retrospective cohorts, as I've mentioned, that this was just like a type of cohort. In general, a cohort is always prospective because it goes from exposure to outcome. Your retrospective cohort is retrospective in terms of time. But when we talk about case control study, the study design itself is uh, retrospective. That is, it is going from disease to exposure. So I hope that's able to answer your question, because one is retrospective in terms of their study design, while the other retrospective type is a retrospective in terms of time, the timeline. Because in general, cohorts are always supposed to be prospective because they start from exposure to disease. I hope that I've been able to answer your question. Both are started from disease. No. So this is what is primarily the difference between the two, that a retrospective cohort also starts from exposure. So what we do is we go back in time and we look at the records and create two groups, that is exposure versus non-exposure, and then look at the present, whether they develop the disease or not. We do not start with two groups of disease and then go back and look at exposure. So it's more like the kind of the protocol that we follow. So that is the difference between the two. Whereas in case controls, we start with the disease groups and look at the exposure. Are there any other questions that I can answer? Or Hafsa, is there any other question that you may have, like a follow-up question to this? Wonderful. Repeat the positively associated with disease concept. Ananya, I'm so sorry, I'm not able to understand your question clearly. Positively, what are you like trying to ask per se? If you can unmute yourself and just explain it so that I can understand the question a little better.
Actually, my net went off at that moment of time, so I could not understand that concept. Can you do a few slides behind? I get to ask the question that what is this concept related to, and someone answers it possibly associated with disease. I'm not sure.
Okay, great. Okay, so when we talk about odds ratio, we can have two or three types, like not two, we can get three outcomes. Either we can have one odds ratio of one, which is there is no association, when that means that the exposure has been equally found in the cases and controls. Okay, so that's the reason we have the odds ratio of one, and therefore there is no association. When there is a positive value, that is like a 3.5 or a 2 or a 4 or 10, that means that there is a positive association, that is that particular exposure is maybe 3.5 times more likely in that particular disease group, that is the example that we were talking is placenta previa, as compared to the non-disease group. And when we talk about a negative like association, so we're talking about something like a 0.2 or something in decimals. So that shows that it is more likely to happen in controls as compared to cases. Does that answer your question?
Yes, thank you so much.
Great. Are there any other questions that we can answer? And we're here to still answer your questions. Please feel free to put them on the chat box. I think this time we would also, it would be a good time that everyone can just switch on their cameras and we can just take a few screenshots. So we'd request all to please switch on your cameras so that we can just see you guys and take a few screenshots. In the meantime, we're also looking at the chat box, so feel free to put in your questions. Thank you, Sana. Thank you, Ananya. Also, please do not forget to fill the post-event questionnaires because that is a criteria that we will be considering for giving certificates. So please fill them up till 10 p.m. Feel free to ask any other questions or any other questions regarding other sessions ahead in the series. We're happy to answer them. We're really thankful for all of you to join us today and give your 1 hour time. I hope this session was really helpful and useful for you guys, and hope you all were able to learn something from it. Feel free to email us or just put your questions on the WhatsApp group if you come across any. Shri, Raji, would you all like to add something or say something to all our members who have been present today?
Nothing much. Just thank you all for attending the session and hope you guys had fun and learned something nice.
Hope you guys enjoyed today's session, and we look forward to having you next time.
We're so glad we've finished right on time. So now you guys can feel free to leave the meet and have a nice day. I mean, have a good night and a great weekend ahead. Bye. Take care, everyone. I'm giving you all a call on WhatsApp. Bye. Bye, everyone.